Today we're just going to do a little introduction into management of patients with non-malignant hematologic disorders, meaning they don't have cancer. The anemias in general, when you think of what anemia is, it's a lower than normal hemoglobin and fewer than normal circulating erythrocytes. Erythrocytes are another name for red blood cells. It is a sign of an underlying disorder. Kind of speaks for itself. Hypoproliferative means that we're not producing enough. Okay, defect in production of red blood cells. And this can be caused by an iron deficiency, a vitamin B12, or a folate deficiency. You could just have it because it's not, your bone marrow is not putting out the red blood cells. And it can be due to cancer, where the blood cells are being crowded out by the cancer cells. In hemolytic anemias, this is where there is actually destruction. So you're producing the red blood cells, they're coming out okay, but then they're being destroyed somewhere in the body, usually by the spleen. It's caused by altered erythropoiesis. Other causes such as hypersplenism. Hypersplenism is when the spleen enlarges due to excessive destruction of the red blood cells. The spleen is where our red blood cells go to be recirculated, if you will, recycled. And when it becomes too active, the spleen gets enlarged and it gets crazy and destroys too many. It can be drug-induced or autoimmune processes that can also cause this problem, and actually mechanical heart valves can also cause this type of anemia. And of course we think of anemia too with blood loss, where you have somebody hemorrhaging and losing all this blood, and so they become anemic very quickly. What you show, what the patient looks like with a manifestation, depends on the kind of anemia it is. If you have somebody who was a healthy runner and got hit by a car and they've got internal bleeding, you're going to see different symptoms of the anemia, this quick blood loss from them, versus somebody who has iron deficiency anemia and just over time has become more and more fatigued and their iron levels have depleted. Fatigue, weakness, and malaise. Malaise, just kind of that yucky feeling, you just don't feel like doing anything. Pallor, pale, or jaundice, where they have yellow discoloration. Now, it's going to depend on the type of anemia there too and what's going on. If you have more of a hemolytic anemia, then you're going to have more of the jaundice, because that's a byproduct, where if it's pale is more likely to be your hypoproliferative anemias. Cardiac and respiratory symptoms, because of course if you're not getting the oxygen you need, and that's what the little red blood cells are circulating around, is the oxygen, your heart and your lungs are going to pay the price. The tongue actually has some changes, and usually this is seen more often in folate or B12 deficiencies. Nail changes, angular chelosis. You'll also see this called angular cheilitis, and it's when you get the little cracks on the side of your mouth. It can be on one side or the other, where the top and the bottom lip come together there at the corner of your mouth. And pica is an abnormal craving of food that is not food, things that are not food, I should say. So the most common thing you see in iron deficiency anemia is people chewing ice. And I know there's always been that kind of, well, ice is kind of a food, it's edible, but chewing abnormal quantities of ice, actually it can be unhealthy for the body, and it's a sign often of iron deficiency anemia. So, what type of anemia results from red blood cell destruction? Is it bleeding, hemolytic, hypoproliferative, or none of the above? And your answer should be hemolytic. Bleeding results from red blood cell loss, results from the destruction. Hypoproliferative results from defective red blood cell production. Diagnostic testing, things that we do most often with patients who have anemia. We get not just a hemoglobin and hematocrit, we'll get a whole complete blood count, a CBC. But the things that we're picking out for anemia specifically is a hemoglobin and hematocrit. A reticulocyte count, that is the count that tells us how well the body is putting out red blood cells. Are they manufacturing the red blood cells the way that they should? The RBC's indices, those are things like mean corpuscular volume. When you look at a CBC, you'll see that there's a large MCV can be elevated, or the MCV can be decreased or normal, and that'll tell us how well the body is producing normal red blood cells that are able to circulate the hemoglobin. Iron studies tells us if there's an iron deficiency problem. Vitamin B12, kind of a no-brainer, tells us if they're decreased on B12, and same way with folate. There's haptoglobin and erythropoietin levels. Those are more specific tests that are done more often if they can't find any information. So that's not going to be their first go-to test. And then bone marrow aspiration, that's very invasive and most often done when there's a suspicion of either cancer or aplastic anemia. So what do we want to do? We want to correct or control the cause. Now, since there's so many different causes of anemia, we can't be specific. You have to figure out what's going on first before you can treat it. Somebody that has anemia from a blood loss that's gotten hit by the car and internal bleeding, they're going to need transfusion of PAC cells. But if you've got somebody with iron deficiency anemia, PAC cells aren't going to be what you treat it with. You're going to treat it with iron. Though I have had to give blood to a child who's was iron deficiency anemia to the point that his hemoglobin was down to 8. And so we did have to boost him up a little and then put him on some iron. Treatment specific to the type of anemia, it can be dietary therapy. We see this more often in vitamin B12 deficiency, iron or vitamin supplementation, iron, folate, or B12, transfusion, immunosuppressive therapy, or there may be something else that you need to treat them with. Assessment, health history, and physical exam. We talked about labs already. Presence of symptoms. How bad is it impacting their life? If they're in there because they've been hit by a car, that's a whole different kind of thing here than somebody who, let's say, has iron deficiency or B12 anemia, that they're just kind of barely can get through the day. They're just so tired all the time. Nutritional assessment. What is your diet like? What medications are you on? An example here of medications that can cause problems is if somebody's been taking aspirin, the full dose, the two of the 325 milligrams of aspirin several times a day because they're arthritis or their foot or they have an injury of their arm, and they have a bleeding ulcer because of the aspirin eating a hole in the stomach, then you have a cause of iron deficiency anemia related to medication. Good cardiac and GI assessment. Are they losing, do they notice any blood in their stool? We could be dealing with something like colon cancer, where they're losing a lot of blood. Blood loss for menses, especially in teenage girls. We see this, that's a big target group for iron deficiency anemia. And again, I was talking about the blood loss in the GI system. And a good neurological assessment, because what can happen is when you're anemic, you're weak, your cognitive function isn't as good, so you don't remember things as well, and you're more prone to falling. And these are some of the looks of what it looks like, the pallor of the anemia, how pale they can look there on the left compared to the right. So nursing process, fatigue, altered nutrition, altered tissue perfusion, and you've got patients who are non-compliant with prescribed therapy. So the complications you can have if you don't get this treated, obviously death if you've got somebody who's bleeding internally, heart failure, angina, paresthesias, that's that funny feeling in your hands or feet, it can be even toes and fingers, confusion, lack of oxygen can cause confusion, injury related to falls. They just don't feel right, and so when there's that fatigue, depression comes along with it oftentimes. So our goals, of course, is to decrease the fatigue, get them up to adequate nutrition, maintenance of adequate tissue perfusion, compliance with prescribed therapy, and absence of complications. We want them to feel better, do better. So how can we balance the physical activity, exercise, and rest that they need? Because they've been fatigued. Just because you start on iron or B12 and even have a transfusion doesn't mean you're going to jump out of bed and run a mile. We need to balance it with their abilities to function. Good, adequate nutrition, maintain adequate perfusion, patient education to promote compliance. Again, finding out what's going on. Do they not have the money to buy the medication that they need? Is the medication upsetting their stomach so they don't like taking it? We need to explore what's going on, of why they're not following through. Monitor vital signs and pulse oximetry. They may need some oxygen while their blood level is down because of the anemia, and potential complications. I want to spend just a tad on the labs here, and this is out of your textbook, and I think it's